Thank you, sir. Your presentation has left an indelible mark on our collective understanding. Continuing further, please welcome the chairpersons for our next session on neonatal surgical emergencies, what neonatologists need to know. Dr. Adarsh Priya Azad, neonatologist at Swami Dayanand Hospital, New Delhi. Dr. Gurmeet Singh, professor at Sri Guru Ramdas Institute, Amritsar. Dr. Pinaki Chakraborty, in charge SNCU, Silchar Medical College, Assam, and Dr. Nisa Ahmed Bhatt, Professor, Pediatric Surgery, Sherry Kashmir Institute of Medical Sciences, Sora. I'm privileged to welcome the speaker for this session, Dr. Sujoy Neogi. I request the honored chairpersons to kindly introduce the speaker.
So I welcome Dr. Sujoy. He's a renowned pediatric surgeon and he has many accolades to his career. So I welcome him and kindly sir proceed to the topic.
Thank you so much, respected chairpersons. I thank the organizers for inviting me for this talk, which is quite important. And I believe that this is a newborn and the newborn has to have a logical conclusion. And the neonatologist and the pediatric surgeon must work rather than antagonizing each other. It should be in synergy. So that would be the best for the baby as well. So this is how I am going to cover. I have only 20 minutes, so I will talk about the abdominal emergencies, some of the abdominal emergencies, not all. I'll talk about lung, CDH most importantly, and something about tracheoesophageal fistula. Most importantly, I love to talk about this topic, which is congenital diaphragmatic hernia, because in MAMC, in Maulana Azad, CDH child means repeated calls for taking up for an early surgery. So, just a quick recap. Congenital diaphragmatic hernia is more common on the left side. Alternately, it is known as the Bogdahl's hernia. Clinically, everyone knows that it's one of the differentials when a child is born with a respiratory distress with a scaphoid abdomen. In my career, I have seen delayed presentations also. Some of them would be event-rations. Most of the babies' diagnosis is clear-cut. Some of the babies' diagnosis needs little more than usual chest X-rays, because you obviously have a loculated pneumothorax sometimes, congenital lung malformations which may confuse. So sometimes X-ray with a Ryle's tube or a feeding tube, or sometimes in extreme cases some dye study also may be quite important. So everyone has seen this, a quick video. By the traditional, in a government hospital, we would go for a subcostal incision. The purpose was just to show you that how we are going to reduce the contents. If you all see, this is the contents we are reducing from the left side of the chest, the intestines, spleen, everything is there. This approach has now become thoracoscopically also, and more we are doing. If the baby is good built, then we can also do it thoracoscopically using staplers or your laparoscopic thoracoscopically suturing. Now this is the most important and the favorite part, and I do tell my residents and the neonatologists also that CDH is a physiological emergency and it is not a surgical emergency. Even if I correct surgically, it is not a guarantee that the child will not go through the pulmonary hypertension. The lung is already hypoplastic. Early surgery which is going to overlap with the pulmonary hypertension phase, that's the honeymoon period when it is going to overlap with it, the child is not going to survive. For us, in surgical literature, delayed surgeries have a good outcome, as delayed as 7 days, 8 days, 10 days. Pulmonary hypertension is the prognostic feature. There are many prognostic factors, but the one which I emphasize in my institute is the modified ventilator index, which is doable and achievable. All you require is a PIP, CO2, rate, and divided by 1000. This is what we apply, and by and far it works for us. Any value less than 40, we have almost 100% survival. And anything value more than 80 with a high mortality. So if we, on the day of the surgery, we assess the MVI, if the MVI is between 40 to 80 or above 80, I would cancel the surgery. I would want the child to be ventilated further and managed for the pulmonary hypertension. Right CDH traditionally has been in the literature known to be poor prognosis, but right CDH many a times is not an emergency. But caution is, right CDH, liver is on higher side. The hepatic vein also sometimes may be a high insertion to IVC. Forceful reduction may cause a kinking, which may be detrimental to the venous outflow or the inflow to the heart. TEF, we all encounter day and day, and the symptoms would be, usually should be diagnosed antenatally, polyhydramnios. If not antenatally, then at least early birth and in the newborn resuscitation. If not, then any newborn with too much frothing from the mouth, in villages unable to feed, pneumonia. So these are some of the ways how they can have presentations. There is not a syndrome, but Vactral H everybody is aware of. And if somebody in our literature, Vactral H has now come, which is H for hydrocephalus. As I emphasized, nowadays in a good center it should be antenatally detected. If not, then at least during the neonatal resuscitation. And an example of an association with Vactral, if associated with Vactral, prognosis is slightly poorer. Most common is type C, upper pouch is blindly ending, lower pouch is having a fistula with the trachea. We have a high degree of suspicion, chest X-ray with a coiling, as you can see here. This is very, very important. The neonatologist must know that if you see a gasless abdomen, then we are dealing with the type A variety. That means this child cannot have a primary repair per se. We have to do a diversion first. Type E is the one which is sometimes very difficult to diagnose because type E and gastroesophageal reflex mimics. So many babies, it is actually gastroesophageal reflex, but at some point of time we need to differentiate. So for that we need pan endoscopies, for example bronchoscopy and esophagoscopy. Type A, as I mentioned, we need diversion. So the neonatologist also must know that this baby has to have, parents need a proper counseling. Type B, type C, which is type C will be the most common, needs a thoracotomy on the right side. Type E is a slightly delayed presentation, difficult to diagnose. We do bronchoscopy and esophagoscopy, and we need a neck approach, not from the thorax. We can approach this fistula through the neck. An example of an esophagostomy, an example of a gastrostomy. Quickly going to the very important concern that many babies are born with abdominal wall defects. Most of you know, basically gastrocrisis are babies who are born with no covering over the intestine, and omphalocele are central defect which have a covering. Now this is omphalocele. The babies' genetic mutations, syndromic, are much more. So theoretically they are going to have a poorer prognosis. Practically, since the intestines are covered, they have a favorable outcome just because the intestinals, the losses are less. This is the state how babies are referred. I was hearing since morning it takes hours to refer. So these are the babies we get. The basic place at a primary institution, they can simply put a cover, a silo, a polythene bag, a Euro bag, something which could prevent losses. This baby will come after 10 hours and despite best of management, this baby cannot be saved. This is a baby of gastrocrisis. So what I usually tell the nursing staff and the neonatologists in my MAMC is to why not send the baby, this is the way how we receive the baby. Why not just a Euro bag wrapped? And this makes a huge difference. This prevents dehydration, prevents the third space loss. All it requires is a leukoplast, a Euro bag, and just tie it around. Some support. This is the way if you send and refer the baby to higher centers, the outcome would be much better. Then in neonatal abdominal, perforation and obstruction is often a very big diagnostic challenge. So in a newborn, we have to rely on clinical signs. So clinically, we need to know how to differentiate perforation from the intestinal obstruction. In a perforation, you will usually find a very tense abdomen and a shiny abdomen which is absent. In an obstruction, we will find peristalsis. Abdomen is not so shiny. Diagnostic is very important. X-rays many times may reveal hemoperitoneum, many times it may not reveal. These clear margins which you can see between the bowel wall, this is the regular sign, which is a sign of pneumoperitoneum. Pneumoperitoneum all around the periphery of the abdomen is a football sign. You may see, you may not see as well. But what I stress is, in every suspected case where you are not able to differentiate, an ultrasound can make a big difference because an occluded correction goes more in favor of a perforation. So this is an example how a shiny abdomen, this baby was obstructed but later on perforated. So shiny abdomen, baby becoming sick, toxic, so very, very important. So like CDH, I also stress upon this part that if there is a perforation, it is not a surgical emergency. We may delay the surgery for 24, 48 hours, but what is important is a drain. An abdominal drain would be a part of the resuscitation. It would reduce the abdominal compartmental syndrome and it would help in the recovery. The child will be much optimal for surgery if a drain at least has been put in the period of resuscitation. And if you are hurrying for a surgery, that outcome is not going to be very, very good. So a drain is must for these babies if you have diagnosed them. This is the baby with the football sign. The same baby is laparotomy finding. We were unable to find, but very cautiously when you saw, there was a perforation in the transverse colon. Another baby, shiny abdomen, as you can see, no peristalsis seen. No pneumoperitoneum or any sign, vague X-rays. I think 60% of X-rays would be like this. But when we opened, it was a NEC totalis, almost non-salvageable bowel. Then obstruction can be upper GI and lower GI. So we need to know the common causes, we all know that. But one must know, just a quick recap, that upper GI obstruction presents more with bilious vomiting. On the other hand, lower GI obstruction presents only with distension. Upper GI obstruction, the child can still pass stools. So it's an obstruction with the stool meconium, the child can pass. But in lower GI obstruction, it may be distension, stools not passed, vomiting may be the late part of the symptom. Right? So, very important, again X-rays, again an ultrasound, and sometimes if you are very sure it's on a lower GI obstruction, an ionic contrast enema is very, very helpful. So again, not an emergency. You need to resuscitate the baby, dysrhythmic lighting has to be corrected, and laparotomy after resuscitation has the best outcome. One of the lower GI obstruction is Hirschsprung disease, and traditionally taught is that if the child is decompressing on enemas, rectal stimulations, then as long as you can defer the surgery, it will be the best for the child. So I worked an algorithm, it's not a textbook. From my personal experience, any child, most units will present with abdominal distension, refusal to feed, bilious vomiting, both perforations and obstructions. So if I summarize, then a shiny abdomen, distended abdomen, sick baby, sepsis baby, we go more in favor of a perforation. On the other hand, if the child is having bowel loops palpable in one part of the abdomen, if you see this sign that it's just a whole abdomen distended or upper abdomen distended, vomiting is more, the child has more of distension, then we can even differentiate whether it's an upper GI or a lower GI obstruction. So this is summarizing mostly from my textbook, different textbooks, and I feel it is quite helpful. Feedback also is that somehow you can differentiate the different types of neonatal distension, which sometimes is very difficult. This is the baby who had a double bubble sign, very common in our practice. This is the baby's operative picture, and you can see that there is a transitional zone somewhere here. So duodenum, there is a transitional zone somewhere here. Another baby with a double atresia. This was the stomach. There was the part of jejunum, one atresia, another atresia. That means the bowel is not continuous. This is another X-ray where we find a triple bubble sign. The operative finding was this, a jejunum. Some mucosal web must have been there. Rest of all the jejunum is all collapsed. This is all dilated. This is how atresia we often encounter in our practice. This is a child with the volvulus, one of the causes of upper GI obstruction. A quick video just to show that how we do the latch procedure. It's a very quick procedure. We separate the colon from the duodenum. We try to broaden the mesentery. And one of the reasons to do it is that to prevent future volvulus. So malrotation can present with an upper GI obstruction, and I just repeated that the child will have predominantly bilious vomiting. He will not have distension. So if you are making a diagnosis of a volvulus or a mid-gut volvulus, not gangrene, but mid-gut volvulus with a distended abdomen of a newborn, you must rethink your diagnosis. Yes, once the bowel has become gangrenous, edematous, then yes, the distension will be there. But a classical volvulus, the child will have almost a flat abdomen. It will not have a distension. So this is the lax procedure which we are doing. It takes not much time, but the diagnosis is very crucial. This is an X-ray where you can see the transition zone in a Hirschsprung disease. The collapsed intestine is the one which is aganglionic, and the upper intestine which is dilated is the normal intestine. Anorectal malformation, everyone knows, we get it quite often. And unfortunately, even in Institute of Mamsie, the minor variants of anorectal malformation, the best of the neonates also sometimes are not able to see because They see an anal opening, they see a meconium coming, but they do not see the caliber. So you can have all variations of anorectal malformation, one of the causes of lower GI obstruction. This is the algorithm which is given in our books. As you clearly see, the treatment is usually advised 20 to 24 hours after birth. Again, not a surgical emergency, not a surgical emergency from the pediatric point of view. In 24 hours, if you see leaking meconium from the perineum, the child can benefit from only a minor anoplasty. But if no, then I recommend that all babies in a very high volume setup should go for a colostomy. Obviously, lower anorectal malformations you can do diversion, or you can go for a primary PSRP, but for the crowd of this neonatologist crowd, I would suggest that you refer the child with the best interest for a stoma. This is the female anorectal malformation. And female anorectal malformation, mostly you will see a vestibular fistula where the child can grow to a certain age before you need a surgery. Many children may bond with a cloaca. Cloaca needs diversion. It's just an algorithm to show. Very important, neonatologists must know that the invertogram for anorectal malformation is a thing of the past now. It caused a lot of stress, intracranial hemorrhage to babies. It was inconvenient. Now what we do is a prone cross-table X-ray. This solves the same purpose. The purpose of this X-ray is to know what is the level of the anorectal malformation, and I would stress again that the time frame is 24 hours. We do this investigation at 24 hours. An example of how a baby can be born with anorectal malformation, a dimple is there, simply can be missed. I have seen many fistulas over here also, meconium leaking, and people are working up for Hirschsprung disease and other things. This is a baby who was born with hypospadias with anorectal malformation. The same baby. This is a vestibular fistula, often missed again. It is only later on when the mother says that urine and the feces coming from the same place. Right? So